the health insurance marketplace is a hot topic, and this is the second webinar that we have done on this topic, as we've been following this whole area for the whole year and are continuing to dive into the details, particularly on the pharmaceutical side. What we want to do today, I want to walk you through first what's hot in the marketplace, and the web, the promise, the politics, talk a little bit about the enrollee experience. Where are we with enrollment? Some of the realities that are starting to unfold with regards to the marketplace and the experiences that people are having, both particularly when they can actually get in and view the plans. We'll do a quick update on coupons and subsidies and where we stand. There has been an update on that. I'm then going to take a step back and go through some of the background, the fundamentals, if you will, the essential health benefits and some of the marketplace fundamentals. And then we're all going to go on a little shopping trip, and we're going to pretend we are looking for health care. And I would, I'm going to assume that pretty much everybody on this call has employer-sponsored health care, so we are somewhat immune from the marketplace. But having gone through a number of these, I want to walk you through how this is really fundamentally changing how people have to look at insurance and what they have to pay attention to. And then we'll end up with what we know now and our ongoing assessment and perspective in terms of the marketplace participants, who are the likely winners, formularies, and then the pharmacy benefit. Well, if certainly a lot of hype and anticipation heading into the October 1st start and launch of the marketplace and the exchanges. And as we got into October, I think a lot of what we saw, probably we began to ascribe to really the politics that was out there. But the reality is, as we came off of our hyperglycemic high after Halloween, and certainly through the Senate hearings and the reporting, and we got into November, we really began to realize that there are some serious problems and issues with the rollout of the marketplace itself. Well, one of the things that we'll talk about, obviously, is the web. This has really gotten a lot of attention, and for good reason. This is clearly the portal to the whole process, and it is broken. I think anyone who follows the news, and there's a lot of it, understands that there are difficulties across the board, both in terms of how it was set up. It's not user-friendly. There's connections that aren't being made. There's also, even on the state exchange side, where there was an error in the state of Washington early on, where they just miscalculated the subsidy, thinking that the weekly or monthly income was actually the annual income. At any rate, when you see how the system connectivity is supposed to work in this, and all of the different feeds to and from all the various disparate agencies and databases, one can see that the complexity of this clearly has become an issue with the time frame that this really had to put in place. So it's really no great surprise. As of today, I know, for example, you'll see the news that the government is inviting people to come back to the website, that there's been an improvement. But on the other side, when one looks at the reporting from the project team, there's real concern whether or not they can get a significant amount of the functionality that's needed in place, fully tested by the end of November, which is really that next target date. At any rate, a lot of issues. You know, quite honestly, for any of us in our respective businesses that have been part of an implementation, I recall when pharmacy claims were being computerized in the 1980s, when pharmacies were being hooked up to networks in the late 80s and 90s. Medicare, even more recently, 10 years ago, it was messy. It didn't work well for months. But at the end of the day, it will get fixed. It may take a while. I suspect it will be well into 2014 before all of this is in place, but it will get fixed. It still doesn't change, and what likely will be some modification of the rollout and accommodation for the people through this. So stay tuned, and we'll certainly see how this unfolds. Well, the other big news, of course, if you like it, you can keep it, and it's become kind of a new tagline. But unfortunately, this is a reality for the new from the Accountable Care Act, that insurance policies that millions of people had just aren't meeting the minimum standards. And therefore, by law, they cannot be in place by 2014. Shouldn't be a big surprise that, by and large, these policies are now being canceled, and members of the insurance companies are being asked to look and find another plan. I provided a bit of background on this just to give you a sense that back in 2011, there was almost 11 million individual policy holders. That's actually increased since that time. Half of those plans didn't meet the 60% minimum value coverage that's required by law. And in fact, a fair number of them have pretty low coverage. On average, it would take almost a 9% premium increase just to get up to that level. In addition, if we recall, and we'll talk in more detail about it, it's the essential health benefits. Very few, in fact, less than 2% of these individual plans provided all the essential health benefits. And on average, it's less than 80% of what is required. And so in order to be able to be on the market, whether you're on the exchange or if a company insures, it has an individual policy on the exchange, they have to offer that same policy off the exchange, would mean changes in the insurance coverage as well as in the cost itself. It's also interesting that an analysis of this showed that those in individual plans today probably would likely qualify for some degree of tax credit for a marketplace plan. So it should be no great surprise. And people are talking about the sticker shock that they get where their insurance is going up is because if you take current coverage, you add in all the benefits, you basically have the limits on cost sharing, you have to meet that minimum actuarial value, then your premiums are going to go up. And it really varies by market, and you'll see across the bottom of the slide a number of different markets for which there could be pretty substantial increases. So what you're seeing is, in fact, what would have been expected is the transition out of the older, less comprehensive benefits now to the new standard that the Obamacare has established. And unfortunately, the saying, if you like it, you can keep it, has never really been true in this market. Unfortunately, what we now have, and I just saw that apparently California is announcing there's 1 million people who are getting insurance cancellations. We've always known that there's going to be winners and losers with Obamacare. You're going to have some of the middle-aged folks have lower insurance premiums at the expense of younger people because of the age band rating. You're going to have folks, for example, who don't have the full benefits who may end up needing to pay more for those full benefits. But I think what's happened on the political side is, unfortunately, between the website, which the winners of Obamacare, people wanting to sign up, have been frustrated with it, and now you've got, in this case, the losers who otherwise would have been probably relatively passive are now contacting their congressman because they're getting the cancellation notice. So it really is both sides boiling up to really create a fairly negative posturing for the rollout of this particular program. At any rate, what about the enrollee experience in that first month? And there was just a survey that was done and released last week. One of the questions is, has it been a day at the beach? And this is from our earlier presentation. The Connecticut State Promotion for for the exchanges actually did a lot with the beach themes, looking at everything from Cover Connecticut, sunscreens, etc. So the question is for you, is the enrollee experience going to be kind of like the Connecticut experience, a day at the beach, or is it going to be more like Minnesota's exchange campaign that actually used Paul Bunyan and Babe the Blue Ox? I suspect folks who have gone through it would vote for Minnesota. Well, what does the tracking survey show? It basically showed that, number one, you actually have the likelihood that those qualifying and eligible adults will shop on the exchange. The good news is that the majority of people were aware of the health insurance marketplaces. You had a fair number of people early in the first month that tried to get into their state's marketplace. And a lot of the folks were young, and this is, again, one of the myths of the invincibles, that they don't want and don't value insurance. Is that has actually been shown not to be the case, is that is a group that likely will sign up for insurance, and again, the survey does show that. It's interesting that about 20% of the folks who went to the marketplace were able to enroll into a particular health plan, and then a majority of folks will likely come back as well. Well, if they didn't enroll, if they actually visited the marketplace, what were some of the reasons? And I think we begin to see here some of the complexity and the real change that this is going to have in the marketplace. First of all, there's the affordability issues. There are, in many markets, a lot of choices, not in all, because, again, a particular market may be down to a particular rating region or several counties within a state, and so there can be a real range of plan offerings and costs as you go across neighboring counties and different rating regions, and so you have that. So still unable to decide. Thinking that the deductibles and copays were too high. Again, we'll talk a bit about that as well. And then we get into some of the technical aspects of it. The reality is, in visiting it, is what this graph shows is really the difficulty, somewhat difficulty, or a lot of difficulty in trying to interpret what was really on the site and how to shop for the various plans. And what you see on the left in the blue is the difficulty, and the easy is on the right, and clearly it's weighted on the left. So in terms of affordability, what kind of plan, kind of benefits offered, potential out-of-pocket costs, again, these are making it difficult for people to make a decision. At any rate, where are we with regards to enrollment? And again, I believe sometime this afternoon the government is likely going to release the actual enrollment figures from the Federal Exchange site. There was an early leak, or at least insight, that Wall Street Journal reported on Monday on what that number is likely to be, somewhere between 40 and 50,000. When tracking all of this, it looks like as of this week, under 100,000 people have really signed up yet at some level for a plan. And again, there's variability in terms of what signing up means. So we're literally, the goal being about 7 million for 2014, pretty far short of that. And I think obviously the marketplace difficulties with the web have really been a big issue and a big concern about that. But again, a lot of people interested in terms of what the enrollment is, where it's going to be, and then projecting out, and we'll talk about it a little bit later on, projecting out where do we think 2014 will come in. If we begin to look at the enrollment, I wanted to break it down a little bit further. Medicaid is clearly the winner so far, and you have to be careful if you're reading enrollment figures. Sometimes, again, the marketplace will report both the combine the Medicaid and what I call the commercial exchange enrollment all as one number. And at this point, it's pretty clear that Medicaid far exceeds that of the commercial enrollment. A lot of reasons for that. First of all, there really isn't a choice. It isn't a dollar issue at all. And many states actually have automatic enrollment programs where they've already targeted folks to really get involved in this. So it's not surprising that Medicaid has the vast majority. But you can see on the top graph California, New York, Washington really leading the way at this point at the various reporting schedules. And I just did see also New York reported this morning that I believe they had almost 191,000 applications so far that have been filed. So this is going to be, again, the numbers game. It's really too early to predict or project where we're going to go with it. One of the concerns is that the longer we go with people having difficulty getting into the site, the more people will try to get on and enroll in a shorter period of time. And one of the issues that was raised this morning was that there still is potentially a capacity issue with how many people could be on the website and having it function appropriately. What are the market realities that we're starting to see, both with the experience that people have had, and also now that that information is available, and we can begin to look at how a consumer is really being confronted by this new kind of marketplace and the new rules. But first is, you know, how do I understand the benefits and how do I navigate all of this? And you know, and unfortunately, even the navigators who are paid and have some degree of training are a bit stymied because they also don't have access to the tools that can really help folks out as well. The other issue is what we've heard is sticker shock, and I'll talk a little bit more about actuarial value in a little bit. But the reality is that we'll have bronze and silver plans will be the most popular plans that are there, and just we call them the metals. Really 4 metals: bronze, silver, gold, and platinum. And of course, then there's the catastrophic plan that isn't considered that's for a limited population. The reality is, in this marketplace, we expect most people to be purchasing the bronze and the silver. We could estimate somewhere in that 40 to 50% bronze, perhaps 30 to 40% silver, and I think gold and platinum are going to be about the more in that 10 to 15%. The reality is that the coverage at that level is really at a relatively low level of 60 to 70%, and relative to our understanding and our experiences with insurance. Medicare Part D, from 10 years ago, the actuarial value there is 75%, and most employer-sponsored benefits are into the 80s. So it gives a sense, kind of to that next bullet, I pay premiums, I pay deductibles, I pay co-pays, so where's the insurance side of it? And this is really kind of the understanding of what am I going to get for my money on it. And again, our case study will walk through that with you. It's all about the network. I like my physician. Can I see my physician? Another one of the promises. That may also become a frustration for folks. Limited networks of physicians and hospitals are relatively common within some of the benefit plans that are out in the market. It's interesting. One of the physician trade associations in New York did a survey just within the last week and found literally 2/3 of the physicians had no idea if they were in a network for the exchanges, or if they said they were not in the network or didn't know if they were in the network. And unfortunately, there's been some complaint that even the list of physicians that are in the network are wrong on some of the websites. And of course, dear to our heart, is my drug covered, and when and how much? And we'll get into more detail on that in a little bit. Let's talk about coupons and copays. We thought we had definitive answer in a letter from the 30th of October from HHS. It basically said that they are allowing coupons and copays and subsidies through the state-based and federally facilitated marketplaces, that they don't consider that a federal health care program. That was followed by a couple days by in a Q&A from the CIO division of HHS that still raised concern about that particular practice, although again this is not an official ruling or regulation. As we've talked about in these webinars and following this, it would be absolutely impossible with the way that the Marketplace is set up for anyone who would have to know whether or not a person had a federal subsidy or not as part of the exchange. Again, it's not like Medicare, and it's not like Medicaid where it's uniform, and if you're a Medicare, you're a part of that particular program. So only 70–75% of the people in the program will actually have a federal subsidy tax credit within this. So in essence, the ruling would suggest, as we would suspect, that this is going to be more like commercial, and therefore these coupons, copays, and subsidies will be allowed. And the reality is there's just no way that it could be operationalized if they made any other decision. So I think at the bottom line on this is the legal departments for any of your companies really just need, again, to build a solid foundation for which the company can go ahead. And I think from an opportunity perspective, create and re-enhance the subsidies that are there. And I'll have a comment about that at the end. Just going to go back just a little bit about the essential health benefits, which is really fundamental to defining what are the kind of the minimum standards for what a health insurance package must have. So the Accountable Care Act requires coverage in the 10 categories. It had HHS assigned it to define it. The Institute of Medicine was commissioned to identify a process for defining the essential health benefits, figuring that the scope had to be typical of an employer plan, and then states were allowed to select their benchmark plan to really define those kind of services. And there was a process by which the state could select from among 10 of the different health plans to select the benchmark. Long story short, at the end of the day, about half the plans defaulted to kind of the standard, what was a default plan. The others actually selected, and what we ended up with is the vast majority of 45 states looking at small group plans. We had 2, I believe, HMOs and 2 state employee plans. 70% of the benchmark plans were Blue Cross and Blue Shield plans within the state, and that should be no surprise at all. Well, the important thing is, again, you've got these 10 categories of services and benefits that now become a part of the plan, and actually a qualified health plan has to offer these. Now, there can be differences, subtle differences within each of these in terms of number of visits, for example. Again, but that becomes part of the actuarial manipulation that takes place to try to hit the metal tiers. Clearly, prescription drugs is a critical part of it, as is mental health, as all of these are. The beauty of this is, for those of us on the pharmaceutical side, is it is really the first time that we've seen prescription drugs become an essential benefit. It was not considered to be an essential benefit, and using the same terminology, when Medicare was established in the 1960s. It was an option when the HMO Act of 1973 was put into place, and so HMOs did not have to offer, although most did. So we finally come to the fact that people are recognizing that drugs are important. The actuarial value, which I alluded to in the metals before, are, again, it's an old term, very familiar to those in the insurance side, but now becoming kind of a new household term. It really establishes the levels of coverage, and it defines, in most plans, the out-of-pocket maximum for a member. And so since the benefit package surrounding, for example, the essential benefits that are there are similar, then the actuarial value is flexed by determining that mix of deductible, coinsurance, and copay level, as well as out-of-pocket maximums that the benefit have, as long as that out-of-pocket maximum doesn't exceed the maximum allowed by law, which is equivalent to that of a high-deductible health plan, roughly $12,700 for a family and $6,350 for an individual. Bottom line is, the higher the actuarial value, the less patient cost sharing on average. So when the platinum is 90, the gold plans are 80, and you can drop silver plans 70 and bronze plans 60, That basically it gives an indication of what the cost sharing difference on average is going to be for the member. But that is different. And again, it's done at an actuarial large population based level. It is different for what percent a plan is going to pay for any given enrollee. And so it can be different. So people can have much different coverage levels, individual coverage levels based on their particular circumstance, their use of services, etc. Within the essential benefits, the prescription drug benefit rule was, it actually had regulation with this, that a health plan must provide a drug in each of the categories, or the same number on each category of class as the essential health benefit benchmark plan in that particular state. There's no protected classes in the exchanges. Clearly, they're allowed to use, plans are allowed to use tiering and use management and prior authorization to have beyond the minimum number that are there, to have non-coverage within the formulary, etc. And just to give you a sense of how this is playing out is, if we look across the 50 states and District of Columbia, and then looking at the benchmark plans in a couple of key categories, you can see that there is a significant range of benchmark low to benchmark high number of drugs in these particular categories. What I have under MS and I have under insulins in parentheses is that, in fact, benchmark plan had no drug listed, which made really doesn't make any particular sense. And again, its USP class is kind of the fundamental. There's another layer looking at HIOS, which is another designation that picks up from USP, for which how plans actually evaluate and identify the number of drugs that need to be in a particular category. I can tell you that this has been one of the most frustrating exercises that plans have gone through in the construct of their formularies for this first year. I've talked to a number of plans who are benchmark plans who cannot figure out how the state came up with the number of drugs on their formulary to be the benchmark number. They could not re-engineer, back-engineer back to come up with the same number. So I just want to throw that out there just as a caveat. Even though there are numbers that are there, we are expecting that by and large, most of the, well, and depending on the state, that the formularies may have more drug represented than perhaps even the benchmark low. But again, we expect, and again, people who've done this on the Medicare side, it takes a year or so to kind of work it through. USP is not designed for a commercial membership. It was really a model that was more appropriate for the Medicare side of formulary development. The other, just very quickly, the new health insurance market must, the states must follow their state requirements for this, and we see, you know, if there's certain requirements for coverage categories or percentages, mail order, specialty pharmacy, that needs to be followed. And this is just an example of the kind of individual state rules around those various items, whether it's drug-specific, category-specific, or site of service specific. This all becomes part of a state's marketplace in terms of how pharmacy has to be dealt with in that case. So you can have a different formulary, different rules state to state, even when you have the same organization, high-level corporate or national entity that's there. Subsidized coverage and services, I want to get through quickly. Again, this is one of the fundamentals of the marketplace, is that for 70 to 75% of the people who are getting into the exchanges, they may be qualify for premium credit, and that means it can help drop the premiums that they pay. And there's a second piece of this, which is cost-sharing assistance, that is available as well. And you'll just see on this slide, if anything, points out the income levels for which people can would qualify at these. And so when you talk about federal poverty level, FPL, again, not a new term, but FPL suddenly become a household term because it can make a difference in terms of from a financial standpoint. And you can see between the single and a family, it's that 100 to 400% of federal poverty level is that range for which these kinds of premium credit and cost-sharing assistance is available. And this is probably the best slide, although busy, but the slide that explains this the best. And so if you're talking about somebody with income, whether it's a family or an individual at a certain level, what the Accountable Care Act says is that the amount that they have to pay, the percentage of their income that they're going to have to pay for health insurance is capped. And it ranges, it's a sliding scale from 2% to 9.5%. So the bottom line is in that column toward the right, see that their monthly dollar amount that a family would have to pay for insurance based on their income is a set amount. And then that then translates to what kind of the actuarial value they may get out of the benefit that they have. So in fact, you can get not only the premium credit, but your 70% silver plan for somebody in the 200 and 250% poverty level. Actually, if you pick a silver plan, you actually can get a slightly better benefit that the out-of-pocket max will drop slightly, so that in fact it's 73%, or the lower your income, you could actually get up to over 90% of the benefits, of the value benefits that are covered. So with that, what does that mean? Well, a new study that just came out within the week showed that about 17 million people who are uninsured could qualify for tax credit. And then about a week or two ago, what we found through HHS is saying that for almost half of the single folks, they could buy a bronze plan for less than $50 a month after the tax credit. And then also in that group, you had over 1 million that could qualify for Medicaid, particularly in those states that expanded Medicaid itself. So we begin to take a look at what kind of affordability that we have here. Well, so there's a lot there, so let's go shopping and let's get into a little bit more details on what this means for somebody who's going in and trying to figure out. So this is the Smith family, family of 4, lives in Los Angeles, California. Bob is self-employed, roughly about a $50,000 annual income, had an individual policy, but just got a cancellation letter. And so now they need to figure out what they want to do. And again, I made him probably alluded to at the beginning, folks with the individual policies were going to be active shoppers and potentially really benefit in those areas where, in fact, their premiums could have some offset and they would be getting greater value for the insurance that they had. Well, if we look at the Smith's medicine cabinet, you can see that they're on a number of drugs. They're on generic drugs, brand drugs. Janet is on a specialty drug for arthritis, costing about $2,500 a month at $30,000 a year. And so there's a mix of generic, there's a mix of brand. They've got, on a monthly basis, if you're looking at the cost before insurance picks up any of the cost of this, a little under $3,000, most of that being driven, of course, by the specialty drug, over $30,000 per year. So their old benefit, they had prescription coverage. They went online and they looked at copay cards when available to really help reduce their out-of-pocket costs to make it more affordable. Well, they're in California, and so if we look at California, we find that originally there were 13 plans or insurers that were offering on the marketplace. We've had 2 now drop off, one just recently, actually it was earlier this month, Alameda. So there's a number of plans here that are offering or insurers are offering plans. Not all insurers offer plans in all regions. And so, just because we see that, in fact, a HealthNet, for example, is offering in California, they're only in 5 or 6 regions, I believe, out of the 19 that are in California itself. So at any rate, what Bob and Janet will do is they're going to go into the Covered California website, and they're going to enter in their information and their kid's age and their income, and what's going to come out of that is they're going to find that their kids actually qualify for Medicaid coverage, which will provide obviously a comprehensive benefit, and then therefore really the insurance is going to be for Bob and Janet. And then you can start comparing the plans that are in your region. You put in your zip code, and in that particular area, in the LA region, there are at least, I put 6 here, I believe there may be 7 or 8 different insurers that are offering plans. And similar to Travelocity or the others, you'll see a bronze come up, and you can rank it according to cost, or you can rank it or you can do it by cost. Some of the sites actually will allow you to do it by deductible, high to low, or out-of-pocket, high to low, a whole range of different things that may appeal to people. What you're seeing here is based on the income and based on the premium, based on the income, the subsidy for Bob and Janet is $467 a month. So going into the website, if you were to look at the list price of the insurance, it's on the left here. For a bronze plan, $561, $583, $644. But with the subsidy, it would drop that cost down to the other side of the arrow. So Bob and Janet say that the bronze plan I can get for $94 a month. And then they look in the silver, again, enhanced silver, $73. Because of Bob Janet's income, they actually qualify for that, that subsidy assistance, but beyond the premium, this additional assistance. And we'll see here under the silver, they look at the lowest cost is actually HealthNet, HealthNet HMO, in this case at $230, and then we see the gold level onto the right. Well, there's a lot to look at here and to think about here, and what's interesting is that the benefits in California are really pretty comparable from plan to plan, and you can compare. And you can list it all out, what your office visits are and all the rest, and you'll see that shortly. And so Bob and Janet say, okay, I'm going to look at the lowest silver and bronze and gold, and let me take a look at what's there. So what about the benefits, and what are the coverage differences? So here's what we have them. We have it at the different premium levels. And what you see is under the bronze, and again, all the bronze are pretty plans. If I had to line up all the bronze plans before, it would look pretty similar to what you see under LA Care. Same thing with the silver. And so what we now see is differentiating the benefits according to the metals. And so the bronze, for example, has a $10,000 deductible and a maximum out-of-pocket of $12,700. As you move over to the enhanced silver, the deductible drops and the maximum out-of-pocket drops. And when you get to the gold, you have no deductible, and in fact, you go back to the maximum out-of-pocket. That subsidy assistance or the assistance, co-share assistance is really only available on the silver plans, which is one of the reasons why silver plans are likely to be the most widely picked plan that's there. When you begin to look at doctor visits, you see differences across the metals. And again, this is as plans have tried to model a benefit to meet the actuarial value, they begin to flex the co-pays and co-insurance. The drug benefit itself, you see $19, which is, I'm going to say, is an odd, actually a very odd number for a generic, only until you realize that the average cost of a generic is around $19. So in fact, most of generics will come in under the cost of what that copay is, and people will pay the lower amount of it. There's brand, non-brand, preferred, and specialty. So basically in California, there's 4 tiers, if you will, with that specialty tier being a co-insurance. All right, what kind of decision making are we looking at here? All right, so you got to first figure out that there's differences in annual premiums. So for the Smith family, it can be as little as $1,100 to as much as $3,800, moving up through the different metals. The question, though, is do they, between the specialty drug, physician visits, lab tests, and anything unknown that pops up, what's the likelihood that they will hit or exceed an out-of-pocket max? And there's a very good likelihood because of the specialty drug that Janet is on. And I think this is an important thing for us to keep in mind. Most families probably would never hit the out-of-pocket max if there wasn't a serious illness, but especially drug, particularly as more become available and they become more expensive, will likely get people to the out-of-pocket max quicker than simply medical, other aspects of medical care. So they're going and thinking, okay, I'm going to hit the out-of-pocket max. What are my choices? And so when you look at the bronze plan, you realize that they have to pay a hefty monthly amount until they get through their deductible. So they're going to be, you know, not only are they paying $11.28 a year for the, or $94 a month for the premium, but they're going to be paying totally out of pocket until they hit that $10,000. And again, their monthly drug cost was like $2,800, so they're going to at least take 4 months to hit the deductible. Then after that, the benefit kicks in. If you recall, it was 30% for a specialty drug. So figuring a rough idea, about $750 for the specialty drug, another $200 for the other drug copays. So they're in for about $950 to $1,000 a month for another couple of months until they hit the max. End of the day, they've got a lot of dollars up front with a total out of pocket at about $1,300. The Silver Enhanced actually lowers their total out of pocket because of the deduct is lower. They also will cross that deductible in about 2 months, and by about March, they're only going to be paying about $500 a month for that specialty drug, and then it'll take them about 8 to 10 months to hit the out of pocket. The Gold plan is fascinating because you begin to think, if I don't have a deductible and my out of pocket max is, you know, at that $12,700, would I even hit my out-of-pocket max if the benefit is picking up the cost or some major portion of it, in this particular case, 80% of the cost of the specialty drug from day one? But again, if we're only looking at a drug, we're not looking at the other out-of-pocket risks that are here. So what are the additional Smith family checklists that we do for shopping? Our doctors and local hospitals that we use in the network. Most HMO plans do not cover out-of-network care, and in many of the preferred provider organizations, they have out-of-pocket, higher out-of-pocket or exclusions for out-of-network care. If their kids, in this case, are covered by Medicaid, where their doctors still see them, are the drugs that they take even covered by the plan? One of the realities here is that if a drug is non-formulary, or it's obtained outside of the network, or requires prior authorization and one didn't go through it, it will not be covered, will not count as an out-of-pocket cost. Do they need to change pharmacies to get coverage? Many of the benefits that we've looked at require specialty drugs to be obtained through a specialty pharmacy network. We are seeing some pharmacy store limitations, not as widespread as I expect we will see them by 2015. And the good news is there's still mail order has lower out-of-pocket incentives in many of the benefit plans. So it really boils down to what's my best cash flow option, and you know, where do I think I might go? So in this particular case, the Smiths will likely choose a Silver Enhanced plan because they do get a benefit when they pick a Silver plan, and also realizing they'll probably have achieve the out-of-pocket anyway, they'll feel protected against any other unexplained medical illness, etc. Once you've gone beyond out-of-pocket, there's no additional cost. And so they at least can bank on that amount. I want to quickly go through, and again, hopefully what I just went through demonstrates the kinds of questions and the kind of detail that folks are going through now, and we'll go through in a fairly abbreviated amount of time once the websites are open. Can go. California is a state-based exchange. It's working quite well. Still has some issues with it, but many of the state exchanges are at least allow folks to get in to do this kind of comparison. So what do we know now that we didn't know, you know, weeks ago or earlier this year? And part of what we've been doing is our ongoing tracking and modeling of states, the insurers, enrollment, and the formularies that are taking place, is that we now know that there's about 235 insurers that offer over 3,000 qualified health plans nationally. If we look at enrollment and start modeling in an ideal situation, and realizing that we are not in ideal based on issues with the website. That with full enrollment potential, the top states, some of the top states you see on the left, California, Texas, Florida, expect well over 1 million members to eventually be enrolled into the exchanges. If we look at what we might expect on 2014, 2014, the CBO and others are saying could be 7 million. Others are suggesting maybe it's going to be 2.5 to 5 million. Or we have an initial modeling. We're looking at about 5 million as a particular number. And then we see where do we expect the states to end up. And this is at least our initial view. Where this is helpful is then to begin to understand who are the key players, who are going to be the winners. And we define winners a number of ways I'll show you in a bit. But we can begin to see that the key insurers nationally and are going to be WellPoint, Aetna, Humana, and Health Net, based on some projected enrollments on some of the models that are there. When we begin to dive into individual states, and we've done this for almost all of the states, we begin to see, based on the premiums that are being offered, the markets that they're being offered, the various plans that are there that the plan has, who's the lowest, the second lowest price in that particular market, who's dominant, and currently in the particular market. You need to set up a formula that suggests that certain players may get more of the enrollment than others. And so you see in California that Kaiser, Health Net, Blue Shield, and Anthem probably in our model, in ours and other models, may get the most enrollment. Actually, the Smith's Silver plan was a Health Net plan, as you recall from just a few slides ago. On that. The LA Care was the low-cost bronze, which again may get some folks who are really looking just for low premium, who do not have high out-of-pocket costs itself. We look at Louisiana, another state, very similar kind of process, using a similar type of modeling that we do see. Again, Blue Cross Blue Shield of Louisiana and Louisiana Health Cooperative, one of the co-ops, one of the 22 co-ops that are been established as part of the exchanges, will actually do pretty well. There's a few states where co-ops actually again, new entities, new players that haven't been there before may end up becoming prominent in their particular region. Another thing that we know now that we didn't appreciate before is what's happening with formularies in pharmacy. What we're seeing as we're identifying the formularies that are being offered tied to specific metals and plans and states is that we are seeing somewhere between 1 and 3 different formulary versions being offered, often tied to whether it's a bronze or particular gold. These typically may be 3, 4, 5 tier formularies. We're seeing value, generic plus or preferred stripped down versions of these, which really, again, trying to reduce the cost exposure that a plan might have. We are seeing more 4 and 5 tier in the exchanges than we've seen typically in commercial, although 4 and 5 tiers has really exploded, particularly between 2012 and 2013 in the commercial and the employer market. We're really seeing this as becoming quite common in the exchange formularies. And we're allowed by the state benchmark minimums. We are seeing some limited coverage, and particularly in some of the key states such as California and Colorado, for which the benchmark plan was Kaiser, Kaiser being a very aggressive managed plan with limited formulary. Part of the interesting things that we're seeing with benefits is that there's a separate brand deductible in some silver plans, and so they've taken some of the deductible, overall deductible, saying like a $10,000, well, whatever the amount is, and just said we're going to have $500 deductible, which is a common one for a family, $250 as an individual in the California market, and so a brand drug has to hit that. The specialty drug tiers, it's usually with coinsurance or very high copays. The generics are paid at first dollar, so the deductible doesn't really apply. Again, that's going to incentivize generics that are there. We are seeing some of the non-preferred, non-formulary covered drug copays escalating into the 50, 75, well, 50 isn't necessarily escalating, but $75 and up. And I thought it was fascinating. I actually came across a plan, one bronze plan, that actually required people to pay cash, submit a receipt for reimbursement. It's the old shoebox effect that, quite frankly, I thought had gone by the wayside 10 years ago, but somebody has actually brought that back, assuming that people will likely lose it or not submit them. Again, part of our ongoing insight is the implications for the pharmaceutical industry are many. More people will eventually get covered. There's new benefit designs, there's new insurers, there's new rules, and new variability in formulary coverage, and absolutely new formularies. And again, this will be, I think, an evolutionary process through 2014 as, again, people realize what worked, what didn't work, how they need to position, what sells, what doesn't sell, and what meets the corporate goals for how and what they want to sell for 2015. There are the new out-of-pocket realities. And I think the Smith case is a good one. And so I think from the industry side, it's a good opportunity to relook at patient subsidies, particularly for some of the expensive drugs that are there, that are out there. I think, you know, the sales account training, account management training, looking at relationships, new and existing entities. And because pharmacy is integrated into medical with the exchanges, there's integrated pharmaceutical management, which also means that there's going to be a greater demand for product value documentation. And does it improve outcomes? Can it reduce costs elsewhere in the system? And does that add value? In a situation where historically these have been segregated and siloed, decision making is now done together. It will increase competitive pricing demands and contracting strategies. There, quite frankly, at this point, unlike Medicare, there is no obligation to add a drug to formulary during the middle of the year. There is not that kind of time frame. And so in order to be added to formulary, and the plan already has a minimum number, the question is going to be, does the value or cost of the drug warrant bumping something else off, or simply adding it on because it's not going to be a negative or detriment to the plan. And potential collaboration opportunity with plans and provider groups as, again, looking at driving better health care and lower overall cost. Once we get through the web, once we get through the sign up, once we get through all the questions, and once we all learn how this game is all going to work, it's all going to boil down to managing the clinical risk of the patient to be able to financially succeed in a very low margin product. At any rate, what I've shared with you in the latter part, or actually through the whole part here, is our insights into this market and into the details. And I would just certainly invite anyone who's interested to hear more about the kind of comprehensive services, whether it's data services, education, support, consultation, that we can offer in this arena, particularly as it continues to evolve, as it grows, as it expands, and it will in the years ahead. At that point, I know I've almost taken us to the top of the hour, but Art, I don't know if there are some questions that we can address before people have to leave.
Yep, absolutely. I'm actually going to start. I've got a statement first for the question. So someone had just offered up the viewpoint of, I guess, just a supplemental little point to something you were saying earlier. So Kathleen Sebelius from HHS will actually announce enrollment at 3:30 today, yep, Eastern Standard Time.
Yeah, and it's going to be between that. Yeah, it's going to be between that 40 and 50. Well, could be between 40 and 50,000. And again, I would incorporate. One of the interesting things one has to be careful with are they breaking out the two different components, the Medicaid enrollment from the commercial exchange enrollment. Good to know. I'll have to stay tuned.
Okay, and so the first question, How do you view drug coverage on the exchanges in the mental health category differing from other markets, and what challenges are presented in that class thanks to the one drug per class requirement?
Well, again, I want to clarify. It's one drug per class minimum, or the minimum number that was in the benchmark plan. And so one is is really highly, is highly unusual, and quite honestly, as I alluded to, it's suspect anyway. I would argue that most plans, and when you look at the benchmark plans, the fact that 70% of them are Blue Cross Blue Shield based, and most of them are small group market based, those would have been the kind of unmanaged, more broad formulary included plans. And so I would suspect there's two things. Number one, there's probably going to be a broad level of coverage. Number two, the number of, the other way to look at this, there are a lot of generics in many of the key categories, and so therefore there's likely to be a large choice available to members that may create a challenge for the branded side of the business in order to get that. When I've been looking in categories for which there are a lot of generics and for which benchmark plans had some limitation, or may have had some of the limitations, it does make it a bit harder for the branded product. But I suspect, again, knowing the benchmarks and understanding the regulations and how these were reviewed, that there ought to be pretty good coverage in those categories. But of course, and again, that's one of the things, if there's interest to actually dive in and assess in a category or several categories across some of the key states, it's certainly something that we could do.
Okay, great. Next question. What have you seen with medical benefit infused drug coverage?
Yeah, medical benefit infused drug coverage is part of the overall medical. It's going to be treated almost the same way, although it's kind of interesting. I did find one benefit that, in fact, they applied a $250 brand infusible drug deductible under the outpatient component of the benefit, which translates to physician office or outpatient clinic. Either way, it really is all subject to the deductible and then out-of-pocket max. And so whether or not, Janet Smith using $2,500 a month of self-administered injectable drug, or she was going in and getting an infusion at the same cost, it would be applied the same, the same way. She would have the same she could have the same liability. Same liability for the particular drug. The only difference might be that under the medical benefit, it might be a 20% coinsurance. If that's the case, well, it's no different really than the specialty that you saw in Janet Smith's benefit for the California plans. But if it's a coinsurance, it's still, what you have is the protection in that case of the out-of-pocket max, for which medical drug and pharmacy drug in the exchanges all loop in together. So just because there may be a separate brand deductible under the pharmacy side or a small brand deductible on the outpatient side, that is applied first, but then as part of the overall total out-of-pocket cost that leads you to the maximum out-of-pocket expense. Before then, there is no liability.
Okay, and next question. Have you seen any actual formularies with products actually listed?
Oh, absolutely, yeah. We've got quite a collection. They're not easy to find, and my team goes through some creative ways, including contacting plans, etc., to try to get them. But yeah, I had expected to be a bit more transparent and a bit more available. I think the websites, etc., are creating some issues to trying to track that down. But yes, we do have those.
Okay, great. Next question. If coupons are indeed allowed, can you expand on your recommendation that drug companies' legal departments need to build a solid foundation from which they can go ahead and create and re-enhance the subsidies that are there?
Yeah, I think part of the concern that is, because there is this, we thought it was you know, a well-defined answer from HHS, and then they kind of backtracked a little bit. The foundation is really there to protect a company in the strategy that they have moving forward. And so, should there be, you know, any contrary guidance that backtracks from the October 30th, then at least any activity that a company has done, you can see has been done on good faith, based on the information that was available, and based on the path that the company has set to make sure that the coupons and the subsidy levels are being designed and implemented in an appropriate way. And again, I think, and that's based on my experience in working with groups who, you know, all of our legal departments are a little bit different. And some are more conservative than others. And the bottom line is that I think in an area where there is going to be a change, you want to make sure that you're protected, that the activities that you did in 2014 were not willy-nilly, that were based off of a solid company directive based on the information that's known. And to the point of expanding, I think that gets into, if you see what the out-of-pockets are and you begin to see what some of the thresholds or barriers to access to expensive therapies are going to be, begin to see kind of where would we need to structure a subsidy to really begin to either reduce that barrier or to remove it altogether. So again, I've got some thoughts and ideas about how one might want to do that. But as I said, because people are going to have potentially more out-of-pocket exposure with the lower actuarial value plans, they may have to come up with more out-of-pocket. And in my experience, it's not the health plans that are necessary, or the formularies that are necessarily going to be the barriers to access. It's truly going to be the patients and their own individual affordability assessments of a product and the value that that product brings to them that is going to be the decision factor. And so that all begins to weigh in is, how do you begin to manage what is now that very prominent new decision maker in this particular process.
Okay, and that is all the questions that we have. So, Joel, I'd like to thank you for a great presentation, very insightful. I think you know, everyone really got a lot out of this. As far as for everyone who's on the line, just wanted to let you know that we will be making this presentation available to view on demand, and you'll all be receiving that in an email tomorrow morning as soon as that is uploaded and ready to go. And other than that, I'd just like to thank everyone for attending. And Joel, thank you once again. And that's about it. Everyone have a great afternoon.
Very good. Thank you all.